So, Philip, thank you so much for that wonderful explanation of predictive coding theory and the linkage with to act and process-based kind of work that we're doing with so many people. And I'm going to transition now and talk about this care kind of approach, a four-step guide. And I'm going to call what happens to a person when there is a significant gap between what they predicted for their lives and what happened, a crisis. So it's a crisis because it doesn't fit. And it starts that cycle of escalating what's going on inside us. And that can result in more and more avoidance and shutting down and moving back and having less and less vitality in life. And with this definition of a crisis, it might be someone um, that had an event happen where this gap occurred as recently as last week, or it might be 2 years ago. So this translational kind of part of our workshop kind of moves this approach into kind of a sequential order, but I just want to say it doesn't have to be real sequential, but I think when we're teaching it, it helps to have some structure and to follow. So I'm gonna just talk through these four steps, and Philip's gonna come in to kind of anchor some of these steps in practice by talking a little bit about the case he just presented, Helen. Yeah, that's what we're going to do for the next 10 or 15 minutes. And then you'll have a chance to observe this approach in action in a demonstration and maybe a chance to practice part of it. So the first step is contextualize, and you'll recall that was on Philip's slide on the left-hand side. So putting the crisis in the context. Um, and there's actually a couple of parts to that, and we'll go more into that. But the first is to contextualize and then to assess what's the person doing and how it's working. So you all will recognize this as a workability kind of conversation. And we're doing this conversation with curiosity, modeling curiosity, and hoping to promote that view or that stance more in the person that we're working with. The refine or redesign, I don't know, we've gone back and forth with what is the R, but what we want to do is take the mental model and shape it, add to it, modify it, refine it so that it is connected with the person's distress, their sense of caring, and so that it starts to offer um, an alternative. Um, then we can move to where we all like to go, which is helping the person expand their repertoire and engage in more behaviors that are more adaptive in terms of how they want to live their life. Um, so those are the four steps. We're going to break it down a little bit. As Philip was saying, all of this mental stuff is happening where it's happening in our body. So the body is the repository of all emotional experience, and we are tuned in very closely to the interoceptive cues that tell us something is wrong. And we need to, this is what this is what is supposed to happen. And when it doesn't happen, um, then we start to step back if it's a covert as opposed to an overt kind of problem. Now, when we do step back, and this is kind of the cycle of avoidance, Philip, that I think Helen got into, when we do step back and avoid um, at a behavioral kind of level, it actually interferes with processing the very healthy kinds of cues that would be there for our emotions. Can you talk just a second about how you saw that in working with Helen?
Yeah, I suppose what struck me with her and was also struck me with many other body distress patients is how how stuck they are on the right side of the model. This is what's happening and this is what I need to do about it. And how difficult it is to get them to talk about what they're actually feeling in their body. You would think they know exactly what they're feeling in their body until you start asking them about it. And notice they have very poor language to describe what they're actually feeling in their body, and it makes it difficult for them um, to react flexibly to what they're experiencing. And what I also notice is that asking them about these things, especially asking Helen about what she's feeling here, will immediately raise her anxiety. It's very difficult for her. And what I like about your model, Patty, is that and it looked so funny at first, but what you teach your patients is also to feel their toes, to find one part of their body where they feel safe, and then they can go flexibly back and forth between the face, the safe part of the body, which may or may not be the toe, and then go back to the more difficult part of the body. And that opened up so much flexibility for me in working with them.
Yeah, I think, people present in different ways, sometimes with the bodily sensation kind of being their ticket to talk to us, and other times it's the lack of anything happening in their body. So I worked recently with a woman who it's one of our case examples for the workshop. She had lost her husband suddenly, and she wasn't feeling anything. Her body wasn't a safe place, and so she didn't tune into it. So to kind of get that wisdom of the body in the room, we will go back to that moment and try to elicit the experience of emotion. So we call this part of the process mindfulness of the body. And we really, in teaching this, Philip, I think it's useful to have people practice this right at the beginning of an intervention where they're first using predictive coding theory to kind of empower their work with someone. So to talk with the person about their body and the importance of the signals that their body provides. So also to kind of find a way to experience those signals, but in the context of safety, that the body ultimately is a safe place to be and a place to anchor and experience everything that's there in a flexible way, as Philip said, kind of moving from head to toe or arm to foot, no particular sequence there, but just that sense of noticing different things happening in the body and identifying areas of distress, discomfort, um, tension, heat, uh, cold, but also identifying parts of the body that feel just fine. They feel just completely safe and good and just stable. And that homeostatic kind of like, yeah, this is good. This is my right knee feels just right, or my left toe, great toe feels just right. And we'll label this kind of as the sanctuary and suggest that the person can go there as we work to better understand what's happening in their life. They can go there anytime, and that we might suggest it if we see signs that they might be becoming more distressed than would be useful for them at this moment in time. And or they can go there on their own. We'll be watching and working side by side with them. So we kind of shift to allow the person more and more time for being with sensations of distress once they know they can shift back and forth flexibly. It's interesting that fellow people do. When it comes to the fourth part of this model expand, and we're talking about what they're going to do, they will often talk about, oh, yes, I'm going to practice going to my left foot. It felt so good. I had no idea that that kind of comfort was there. So, the second part of contextualizing the body is here to help with this process, but also the context of the story and telling the story and understanding all of the story, understanding parts of the story that we have not heard in maybe the initial explanation provided by the person, like maybe not having heard that their father died, and that's when that started. So, as we listen to the story, our effort is to validate, show caring, to normalize the experience of a crisis and something that doesn't go away, and that we don't have a story or a way of kind of putting into place, um, and how important it is to open to maybe a new way of looking at the current um, dilemma the person has, kind of the way the story they've created, how it's working for them, and the value of it. So this is assess and look at the value of the story in terms of its adaptation for the person who's on the brink of a new chapter in their life, but they don't have a they don't have a chapter title for it, and they don't know how to turn the page, so to speak. Um, so this is, exposure, bringing difficult experiences into the room, being with the person. And then we move into this refine, redesign, where we are puzzling about the story and its interface. Um, People want to have precise mental models. They're looking for sameness. That's the easiest, that's the best. Oh, that's what this is. We move on. And predictability. And when things happen to us in life that are disruptive and that we didn't predict and that we have no control over, it takes a minute to kind of reevaluate that and look at that and grow into a new way of being. While this work can be done, um, rolled out completely, all four steps in a half hour. It doesn't have to be. And there is typically at least one follow-up where the person goes after kind of working with a shift in the model that promotes acceptance and allows for a revision, a refinement of the model, and a plan to go out in the world, vary their behavior, do something different that's consistent with this new mental model. Um, it takes that going out and getting some new experience, I think. And most people will want to check back, at least by phone, to say, this is what I did, this is what happened. And this is just to have a witness of, you know, I have a new mental model. And to say it aloud and to have that affirmation. Um, I think it starts to happen quite naturally that people add on and add on and add on. But Philip, say a few words about Helen and the points. I think particularly um, um, number three, number four. I think that case really illustrates these points nicely.
Yeah. Well, well, thank you. And maybe if I just can say a few words regarding the first step with the mindfulness, because getting back to the book I talked about earlier that Kirk and his colleagues wrote, it was so moving to read examples of patients for whom it was extremely difficult to be mindful, who even got angry when presented with the idea how skillfully the clinician worked with all of that. So it all sounds so easy now that we're talking about it, but if you want to apply that to difficult cases, or if you want to be moved by a difficult example, read the book. Um, it really did a lot for me. And moving on to point three, what really did a lot for me as well is asking myself exactly the question you were just asking. What is the mental model that the person sitting in front of me is running up against? So with Helen, the mental model was to stay safe, I need to avoid these food and drinks. And we tried to kind of help her get defused from that model. You don't necessarily have to find a new model. The really important thing to ask is, does this model work for you? Um, yeah, and then uh, things almost naturally evolve from there. But then also asking myself this question, what is the model that this patient is running up against helps with so many other patients, like take, chronic fatigue, for instance, something that we're increasingly confronted with given the COVID pandemic. Um, I mean, the mental model that many of our chronic fatigue patients run up against is, I need to work hard and I need to accomplish things to be okay in the world. And that's a model that worked perfectly well from them, up till when they had COVID and suddenly they were tired for weeks on end. And they tried to kind of, push against that wall, and that prolongs the fatigue. And helping them see that this is a model that has worked for them back then, but no longer works now, and diffuse from the model and see what the fatigue they're experiencing might want to tell them, get back in touch with it and find a new model. If your fatigue wasn't your enemy, but also your friend, what is it trying to tell you? And then the last thing that I was thinking as we were talking, Patty, is how beautifully this model is also flexible. For you, it works in these 30-minute sessions. And for us, it also works over a more extended inpatient stay that we have with our patients. And it can carry different kinds of services.
Absolutely. I think it's a very flexible kind of approach and can be adapted to meet the requirements of different practice settings. I think the practice setting kind of influences the expectations of the people served there, the role of the clinician. And when you kind of think about that and adjust it, it can be used in a lot of different contexts. I think it can be used in emergency departments. Uh, Katrina, the Kirk's co-author on the book, worked in the emergency departments in Sweden for a long time. I have worked for years in general practice or primary care settings where um, traumatic experiences are very, very common and are intermingled with physical complaints. So people come and sometimes with a recent crisis and sometimes with the experience of a crisis that's in the distant past, and their life is no longer reflecting what they really care about. I think, you know, the um, chronic pain experience is often um, triggered by events that are traumatic and where there's a huge gap between what the person predicted and how the turn that life took. And so I look forward to seeing this used by people that are working with those among us who have persistent pain. It's such a huge challenge to live with. Yeah. Well,
And I suppose, and I suppose that also segues nicely to what we want to do in New Orleans is really discuss this model with you. And we're curious to see, what questions you have. And I suppose we believe that a lot can be done with it to develop more powerful ACT interventions. And I suppose we're really curious to discussing this with you.
I think it'll bring some freshness to your perspective. So we hope to see you there. Thanks, Philip.
Thanks, Betty.
Mhm. And we will stop.